Hello there, my name is Scott Gill and welcome to my presentation where I'll be discussing the prevalence and coexistence of comorbidities in persons with chronic obstructive pulmonary disease and also touching on the mechanisms for their association. So just a brief background on the disease itself. So chronic obstructive pulmonary disease, or COPD for short, is a disease in which lung airways are persistently obstructed. Now this is a progressive obstruction. Over time this gets worse. Now the pathogenic mechanisms for this disease include damage to lung and alveolar tissue, inflammation and fibrosis of the bronchial wall, and hypersecretion of mucus. Now the inflammatory responses generally occur as a response to noxious particles or gases. Recent global estimates suggest that 11.8% of men and 8.5% of women over the age of 40 actually have COPD. So it's quite prevalent. Now, there are numerous risk factors for this disease, but the greatest risk factor appears to be smoking, which causes COPD in roughly 85% of people. Second to that, a genetic deficiency in alpha-1 antitrypsin may also cause COPD. Now, alpha-1 antitrypsin is a serum protease inhibitor that inactivates specific enzymes which may actually cause damage to lung tissue. So, as an exercise physiologist, why am I talking about COPD? Well, exercise training actually results in a significant reduction in dyspnea or breathlessness. Now, there is much evidence to support this claim, but this here was one of the first studies to show the benefits of exercise training for persons with COPD. So in Reardon et al., they randomly assigned 20 persons with COPD to a treatment or control group. The treatment group did light weightlifting, stair climbing, treadmill walking or bicycling at an intensity of a moderate amount of dyspnea or max heart rate between 70 to 85%. This was done for 12 sessions over a 6-week period. Now the control group itself did no training. So what I want you to take note of here is in the left table we've got some variables for the control group and the treatment group. Now if you look at the third last variable, D max, which is dyspnea at maximum workload during an exercise test, the treatment group significantly reduced their dyspnea maximum workload between baseline and post-training, therefore showing that the exercise training decreased their dyspnea levels. Furthermore, this nice little graph on the right here shows the 10 participants who were in the treatment group who got the exercise training. Now the y-axis shows dyspnea expressed as a percentage of visual analog scale line length, and the x-axis is time on a treadmill walking test. Now the dark line is at baseline and the dotted line is after exercise training. So as you can see clearly in the majority of participants in this group, the exercise training actually resulted in a reduction in dyspnea symptoms during a treadmill walking test. So it is very important to understand the prevalence and mechanisms behind the common comorbidities of COPD, as they are very common. In Maple et al., they took a sample of 200 persons with COPD, and each person had an average of 3.7 comorbidities. Persons with COPD are also more likely to die from comorbidities than from COPD itself. Now this table here clearly shows a classification of cause-specific mortality in COPD patients, and as you can see there's quite a high prevalence of different chronic diseases. So the objectives of this presentation are to describe the prevalence and coexistence of comorbidities, to discuss the mechanisms for the association of these comorbidities with COPD, Now I'll be touching on the main comorbidities that occur here, which is cardiovascular disease, lung cancer, osteoporosis, diabetes, musculoskeletal dysfunction, and depression. Finally, I'll also provide some practical applications that an accredited exercise physiologist could implement into their practice when working with these individuals. So due to the differences in definitions, methods used, and population samples, the prevalence of coexisting diseases in persons with COPD varies quite significantly. So it's quite hard to get a single number on the comorbidities that occur. So as you can see in this nice little table here in Chatila et al., they've had a look at several studies that looked at the prevalence of different comorbidities, and you can clearly see under the different comorbidities there's quite a large variance in their prevalence. However, a recent review by Nagiwo et al. Nicely summarises the prevalence of comorbidities from reviewing all the other studies, and this is the one that I'll be using for this presentation. So the first chronic disease of interest here that I'll be discussing is cardiovascular disease. Now this entails several different diseases. Firstly, ischemic heart disease, which has about a 12.5% prevalence according to Nagiwo et al. Cerebrovascular disease, which has about a 10% prevalence. Peripheral vascular disease, 16.4%, and heart failure, which is 7%. Now, the reasons for the co-occurrence of COPD and cardiovascular disease may be due to the common risk factors shared between the two diseases, such as older age, cigarette smoking, and sedentary lifestyle. Systemic inflammation from COPD may also play a particularly important role in the formation of atherosclerosis. Atherosclerosis in turn produces low-grade inflammation with increased numbers of immune cells similar to those found in COPD patient lung tissues. Hence the link between the two diseases there. Now, there is less evidence for the association between COPD and heart failure, although cardiac function may be reduced in those patients with emphysema due to a lower intrathoracic blood volume. Now, this is because emphysema causes hyperinflation of the lungs, which reduces intrathoracic blood volume itself. But in all, it is unclear whether COPD significantly contributes to the development of cardiovascular diseases, or that they just merely share so many common risk factors. The next comorbidity of interest here is lung cancer, which seems to have about a 4 to 18% prevalence in individuals with COPD. Now, the mechanisms for its occurrence may be due to increases in inflammation and oxidative stress, which heightens the chance of developing lung cancer in COPD patients. Now, it's interesting to note that smokers with COPD are 3 to 4 times more likely to develop lung cancer than smokers without COPD. So as you can see in this nice little figure here from Barnes and Sally, individuals who smoke and who have COPD have greater levels of inflammation, greater levels of oxidative stress, and greater levels of EGFR, which is epidermal growth factor receptors, which may accelerate cancer growth. So once again, it's the COPD here, which has a significant role in the cause of lung cancer. One of the other comorbidities that occurs often with chronic obstructive pulmonary disease is osteoporosis. And in Nagiwo et al.'s review, there seems to be a large variance between studies in the actual prevalence of this disease with COPD, somewhere between 9 and 69%. Now, the mechanisms for the association between osteoporosis and COPD may be due to the common risk factors they share, such as older age, poor mobility. Often COPD sufferers smoke, have poor nutrition, a low body mass index. They use inhaled corticosteroids and oral steroids also to treat COPD, which may lead to osteoporosis. COPD itself may be a risk factor for osteoporosis due to the effects of systemic inflammation. So once again, this systemic inflammation by COPD is showed up here. It seems to have a significant role in development of diseases. Several inflammatory mediators stimulate osteoclast activity, which actually results in bone resorption. These inflammatory mediators include tumor necrosis factor alpha, interleukin-1 beta, and interleukin-6. However, the hypothesis that COPD causes osteoporosis is still yet to be definitively elucidated. So there still needs to be a little bit more research on the association between these two. Diabetes is a morbidity that often occurs with COPD, and this happens in roughly about 14.5% of COPD sufferers. Once again, the reasons for the association between COPD and diabetes are not yet fully understood, and it's unlikely to be due to the inhaled corticosteroids that COPD sufferers use, as persons with mild COPD who don't use corticosteroids are also at a heightened risk of developing diabetes. But once again, it may be related to the systemic inflammation that COPD causes, as pro-inflammatory cytokines such as tumor necrosis factor alpha and interleukin-6 can increase insulin resistance. The next morbidity of interest here is broadly termed musculoskeletal dysfunction. Now, this is a common occurrence in individuals with COPD, and it results in roughly 20 to 30% reduction in limb muscle strength, so it's quite debilitating for these individuals. The mechanisms may be due to periods of inactivity. COPD sufferers, because of their heightened dyspnea, are less likely to participate in activities or exercise. Systemic glucocorticoids and malnutrition. Once again, this keeps showing up, but systemic inflammation and oxidative stress may in fact contribute to muscular atrophy and limited exercise tolerance. And Pinto-Plata et al. Showed C-reactive proteins, which is an inflammatory cytokine or messenger in other words, was inversely correlated with a 6-minute walking distance in people with COPD. So those individuals with high levels of C-reactive protein or inflammation showed less positive results on the 6-minute walking distance, and this is because the inflammation has a significant role in musculoskeletal dysfunction. The last morbidity that I'll be discussing in this presentation is depression. Now, this has a prevalence of about 24.6% according to the review done by Nagiwo et al. Now, the mechanisms for the association between depression and COPD are yet to be properly understood, but it's most likely to be relatively complex and multifactorial. The detrimental effects of aging, smoking, and hypoxemia on brain function are no doubt likely to contribute. However, evidence is mounting to suggest once again the systemic inflammation caused by COPD may contribute to this morbidity. And once again, it's interleukin-6 which plays a particularly important role in the genesis of this morbidity. In the last part of this presentation, I'll be discussing practical applications that an accredited exercise physiologist could implement into their practice when dealing with persons with COPD and comorbidities. So as COPD is a multidimensional disease, more often than not occurring with another disease, as we've just seen, A multifactorial assessment tool should really be used to stratify the patient's level of risk. And that tool is known as the BODE index, or the Body Mass Index, Airflow Obstruction, Dyspnea, and Exercise Capacity Index. And this is used to stratify the patient's level of disease and level of risk of mortality. So as you can see here, we have 4 different variables. We have forced expiratory volume in 1 second. We have the distance walked in 6 minutes. We have dyspnea scale level. And we have body mass index. So the highest number of points an individual can score on this index is 10. That would be very severe disease. 1, on the other hand, would not be a severe disease at all, it would be very mild. So for example, if an individual walked, say, 170 meters in the 6-minute walk test, they would score a number 2 for that variable. Each variable is calculated, a score for each variable is calculated, and it comes up with a total score out of 10, and it gives the practitioner an indication of the level of patient's risk when dealing with this disease. The next practical application that can be implemented by an accredited exercise physiologist is, instead of using heart rate to determine exercise intensity, which is commonly used, a dyspnea rating obtained from a graded exercise test is probably more appropriate. Now, on a scale of 1 to 10 on a dyspnea scale, it seems to be that a rating between 4, slight to moderate, and 6, some difficulty, is the best intensity for exercise for these individuals. As mentioned previously, COPD sufferers often see significant reductions in skeletal muscle strength. Consequently, resistance training should be a focus of all exercise interventions for COPD sufferers. Now, due to the likelihood of experiencing greater than normal dyspnea during activities of daily living, training the musculature of the shoulder girdle are probably more beneficial here, so they can carry out activities of daily living with more ease. And finally, the last recommendation is, because individuals' inspiratory muscle weakness actually contributes to their exercise intolerance and heightened dyspnea, inspiratory muscle training can be quite effective as it enhances respiratory muscle strength and endurance. So this is an inspiratory muscle trainer here, and you basically breathe against resistance, making it harder to breathe and therefore developing strength. The recommendation suggests to do this 4 to 5 days a week at 30% of maximal inspiratory pressure for a total of 30 minutes in a day. Now that can be separated into say 3 sessions at 10 minutes or 2 sessions at 15 minutes. It doesn't really matter. Now the type of device, there's 3 types. There's inspiratory resistive training, threshold loading, and normal cavernous hyperpnea. But the data suggests that no device in particular is superior to another. Thank you for listening to my presentation. I hope it provided some insight on this topic.